about if this mutation was V600K? Does that make a difference then in terms of the response?
It doesn't make a difference in terms of the decision making we just discussed, and that is the individual patient in front of you, what's their volume of disease, what is their baseline LDH. We know that that BRAF and MEK inhibitors work with V600K. What we know, though, is that they tend to work for less time, but you can't predict that, and that's not for every patient. It just seems to be a trend. As Tony was saying, when you look in large numbers of patients, the V600K patients seem to have a shorter progression-free survival on those drugs than V600E, but in general there is a curve of some people who do very well long-term within each group, V600E or V600K. I just wanted to highlight the point Tony made, and that is these durable responders with immunotherapy and the durable responders with targeted therapy, BRAF and MEK inhibitors, may be the same population. Yeah. We don't really know, and I think the randomised trial we just mentioned of upfront immunotherapy versus targeted therapy is critical for the field. But if you look at normal LDH coupled with fewer sites of disease, I mean, these sort of patients have a 3-year overall survival on BRAF. This is 3-year overall survival, well above 50–60% at 3 years. So I think we need to be careful in this data-free zone. The one thing, though, that does drive drives my decision-making is the emerging data of the landmark progression-free survival, particularly as it gets out to 2 or 3 years. Now, I have to remind everybody that the only phase 3 randomised 3-year overall survival and progression-free survival we have comes from dabrafenib and trametinib. We don't have the 3-year in any other combination or immunotherapy yet. That will come. But once we start getting out to 3, 4, 5 years and see the pure activity of the drugs, looking at these landmark progression-free survivals, then we'll be able to have better conversations about giving upfront your very best treatment that's going to give you the most durable response.
And picking on what Georgina's saying, these patients with normal LDH and only 3 sites of metastasis or less, there's a tail of the curve in the data that was presented from both the COMBI and the COBRIM trials, where you can see that patients at 2 to 3 years seem to have plateaued on the relapse rate, which is what we would expect for immunotherapy, not for targeted therapy. So maybe we'll have to redraw our expected survival curves, at least I would have to.
But I think that this is also something, at least out in the community, seems to be sort of a dogma that has become the rule, in the sense that if you're going to be a BRAF/MEK combination, that you will not have any long-term survivors. But I think your data, Georgina, clearly shows that there are long-term survivors for these patients, as something that is not known out in the community, which I think is really important to, as you said, emphasize also that there are some of these patients.